the heart. If you are in the first floor on the left, you will see lead 1 AVL, the left of the heart. If you are on AVR, if you are on the right of the patient, you will be looking from the right. Again, this looks very complicated. I'll show you that it's not. We go back to the helicopter. If you are sitting on a helicopter and a car is coming through the highway, you can easily tell me the car is coming towards me or the car is going away from me. The car is going 90 degrees from me or is coming towards me. So according to what we see, we look at this distribution and we look here very easy. You tell me, of course, I cannot hear you. Where is the highest R wave? In 1, lead 2, lead 3, AVR, AVL, AVF. Let's say the highest is in L2, right? So it's going towards L2. Second highest is AVF. Here you are. As I am with the helicopter sitting here, I see it's coming to me in L2. If I measured in AVR, I think it's going away from me. So you see the light is coming, or the stimulus is coming this way. This is a normal axis, which is positive in lead 1, not as much as in lead 2, because it's on lead 2. AVF, this area from what we call 0 degrees to plus 90 degrees, anywhere in here is normal. Here, where is the highest? Not in lead 1, not in 2, not in 3, definitely not in R. Yes, in AVL. AVL is here. So I am in the first floor of the building and it's coming towards me. It's more negative than 0. And it's definitely quite negative in lead 2. That means that it's going away. It's in that area. If it's in that area, that means that what we call left axis deviation. Where is the highest now? In 1, in 2, in 3. In 3, that means that it's going somewhere here. If it's going somewhere here, I see it better coming to the right. So that's the right axis deviation. Now, you remember this is the PQRS and T, the P wave, the QRS complex, and the T, the recovering of the heart. Remember the P, we were saying it's the car coming from Pretoria, crossing the bridge with or without delay. In this case, no delay, normal delay. And here comes the depolarization of the ventricle. What is the QRS? is the depolarization, is the impulse going through the ventricles. This is completely normal. And the T wave is the ventricles recovering. You know why the name is so simple? Why the waves were named P, Q, R, S, T, like the alphabet? It makes too much sense. It's because the one that named it wasn't a physician. That's why it was made simple. This you see in the same line that we call it isoelectric line, start the P, start the QRS, start the T. Let's see what happens with the QRS and the T wave when there is ischemia. The P is normal, the QRS is normal, but the segment that joins from the QRS to the T, the J point, is low. But in the first case, A, it comes back to normal very quickly. There is no ischemia there. In the second case, the P is normal, the QRS is normal, but when the line has to go back for the T, instead of going back, it goes down or it goes horizontal, and it takes more than 2 millimeters, more than 2 small squares, which is 80 milliseconds. You don't need to know that, but just 2 small squares to go back to the line, to the isoelectric line. That is myocardial ischemia. This is ischemia with downsloping. This is ischemia with horizontal ST segment depression. We call this segment ST because it's the segment that goes from the S to the T. So this is the whole secret. How is the ST? Here, the ST is not normal, but it goes quickly back to normal. If it goes back to normal in less than 2 small squares, it's not ischemia. But if it goes back in more than 2 milliseconds, 2 small 2 millimeters, 2 small squares, like here and here, that is considered ischemia. And here you are, patient, doesn't matter which lead this is on, but you see the J point, where the junction where the QRS meets the T wave, the ST segment is depressed. And how much is it depressed? Look, is almost 2 millimeters. And it takes more than 2 small squares to go back to normal. Through here, through here. This one is horizontal. This one is downsloping, downsloping. Here is hard to say because the QRS is white. So it could be because of the white QRS. Here you have a patient, you put him on the treadmill, and suddenly you have the ST with the J point down. You see, it's not in isoelectric line, it's down at least a millimeter, and it takes more than 2 millimeters to go back to normal. Through here, through here. Here I wouldn't say, but here definitely. And look in V4, V5, and V6. It even goes down. So it's ST depression, ST segment depression. J point is depressed, the ST is depressed, is down sloping, and it takes definitely more than 2 small squares to go back. Now, interesting, when I am looking at this from lead 1, if you remember, lead 2, AVF, lead 1, lead 2, AVF. So all this area, V4, V5, V6, we'll see the areas in a short while. Here you have a patient. The ST is a bit depressed, but not much. Let's see if we get better. Look here, without any doubt, is 1 millimeter, more than a millimeter depressed, and it takes a long time to go back to normal. Long time means several small squares. Look here and here. This is myocardial ischemia. Here again, myocardial ischemia, you see there is the ST depression is, the ST segment is depressed here too, but here it goes quite quickly back. But here you see it doesn't go back quickly. Here doesn't go back quickly. Here definitely doesn't go back quickly. Now let's see what a myocardial infarction looks like. Myocardial infarction now it's has two definitions. You can have myocardial infarction with STEMI, ST elevation myocardial infarction. The ST, that means the point where the S wave or the last wave of the QRS meets the T, J point is elevated and comes down to the, takes time to come back to the isoelectric line. Or the non-ST elevated myocardial infarction. Myocardial infarction where the junction between the S, the last wave of the QRS, meets the T wave, is depressed and it takes a long time. So this one is ST elevation myocardial infarction. This one is non-ST elevation myocardial infarction. And you can come and tell me, but how do I know that this is non-ST elevation myocardial infarction, or it is just myocardial ischemia? Basically, is the time that stays there. So if you see a patient that comes with chest pains and suddenly he has giant positive T waves, you can be seeing the beginning of a myocardial infarction. then if suddenly the ST, even the Q, let me go back to this. The Q is the first wave of the QRS. The first positive wave is the R. The first negative wave is the Q. The second negative wave is the S, QRS. Many times in many leads, you won't see the Q or you won't see the S, but still we call it ST. Here, you don't see a Q, you don't see an S, but still we call it the ST segment, the segment that joins the last wave of the QRS with the T wave. And see here, second stage, after minutes, you will see as the ST is elevated. It takes a while to go back to the normal line. If you wait a little bit more, the Q waves will appear. A Q wave that is more than one small square wide, or more than 1/3 of the R wave deep, is a pathological Q. So this Q means that it starts having necrosis there. When you are in this stage, there is still no necrosis. Here, there starts being necrosis, but still we are in acute stage. This is hyperacute stage. This is acute stage. And look, like the T wave, the ST is coming down, but it's still elevated, but the T wave is becoming negative. It was positive. If you wait a bit more, the Q is even deeper, always white. The R wave is smaller. The ST is coming down, but the T wave is becoming negative. Eventually, all what you have is a Q wave and a negative T wave. Okay? And eventually the T can become normal or stay inverted, but you already have a Q. Sometimes in some patients you see the Q and a persistent ST elevation. When that happens, we suspect that we are facing a left ventricular aneurysm. So again, what do we see in the myocardial infarction? Hyperacute phase. You still don't have the ST elevation, but you have a giant T. Quickly, ST elevation, but not T wave. Then eventually you get a Q. If possible, to treat the patient as soon as possible to avoid having Q waves, to avoid the necrosis. So we take the patient and we treat him in ICU with Actilase, or if possible, we take him to the cath lab and we try to open up that artery as soon as possible before we have irreparable damage. So as time goes by, you are having Q waves, necrosis, the TST is coming down, and there is inversion of the T wave. A little bit later, the Q is even more pronounced. I am losing the R wave. The R wave meant healthy myocardium. Every time I have more necrotic myocardium and less healthy myocardium and negative T wave. Here I don't have in that area. Doesn't mean that the whole ventricle is necrotic. In that area, I see a Q, the R wave is gone, and I have a inverted T wave. And eventually I can have a Q, the T can come back to normal or not. When I see after days a Q wave, which means necrosis, with persistently elevated ST segment, then I suspect that not only I have necrosis, but I have a neurismatic area. So this is what happens from normal to weeks later. Normal, he comes, he complains of chest pain. I see ST elevation. I see a big T, nothing compared to the normal T. More ST elevation, more Q, less R. More Q, less R. More Q, less R. I still have ST elevation, and that wonderful T that became a giant T is becoming a negative T after 1 or 2 days. Days later, I have this already, Q with less R than what we had at the beginning, and an inverted T. The T can go back to normal or can stay inverted. So obviously we want to act here with thrombolysis, as I said, or if possible, if we have a cath lab and we have a cardiologist, we try to take the patient to the cath lab and open up. That it's not always possible. Remember the Q, because we have seen normal Q waves, but the Q to be pathological, it has to be more than 1 millimeter at least wide and at least 1/3 of the R wave. Here you are, more than a millimeter and deeper than 1/3 of the R wave. So if he gets lucky and he's quickly admitted, you see this was normal. P, QRST, you only have an R here. Then in admission, we see the ST elevation. After 1 hour, only 1 hour, you have Q wave. After 24 hours, you have Q wave, no R whatsoever, an inverted T wave. Here, it's late to intervene. And after 1 year, I can see a Q wave, I can see some recovery, but there is necrosis most probably. Here you have again, this patient comes with a P, QRS, T, big T wave, big T wave. He's having pain. Now the ST is elevated. You can see it. I have a small q, but eventually the q, which represents necrosis, is wider and deeper. And it's like pulling down the R. It's eating the R wave. It's eating the normal, the healthy myocardium. And as time goes by, more Q, less R, less ST elevation, but he is completing his infarction unless we stop it. More Q, less R, T wave inverted. Not always the T goes back to being normal. Now, this is how the patient presents with ST elevation, I see it in V1, I see it in V2, V3, V4, but I see some also in lead 1 and AVL. On the other side, I see ST depression. This is what we call in the inferior leads. So now we'll start not only speaking about myocardial infarction, but trying to localize where is the myocardial infarction, in which wall. And if I go back, sorry, I see it in V1, no, in V2, no, but I see it in V3, V4, V5, V6. I saw it in lead 1 and AVL. So I am seeing the anterior segments and the lateral segments. Remember, I am sitting here in the balcony of the first floor. It's happening in the left side of the heart and in the anterior leads of the heart. Here, again, I see ST elevation in the anterior leads, but not only in the anterior. Here I see it V1, V2, V3, V4, V5, V6. So it's septal leads, anterior leads, and lateral leads. Now here I see ST elevation. Do you see it? In lead 2, lead 3, and AVF. And also in V6, with mirror image, the ones going down in the anterior leads. So if I go back, and I said, I see it in lead 2, lead 3, AVF. So that involves, remember, F, feet. It's happening in the inferior segments of the heart, in the inferior wall. And V6, lateral. So inferior and lateral. Now I get a patient with this. There is some ST elevation, but what I see very well that there is a horrible Q wave. There is no R here. It's a Q wave. Is it more than 1/3 of the R? Of course, it's more than 100% of the R because I see no R. Q, still some ST elevation and inverted T in V1, in V2, in this is not a Q, but a small R. So it's happening in V1, V2, and V3, the septal segments. And here you have something that describes it very nicely. Lead 1 and AVL are the ones that I see from the balcony of the first floor on the left. That is lateral. And V5, V6 is also lateral. V1, V2 is septal. Lead 2, lead 3, and AVF, remember AVF, feet, floor, inferior. V3, V4, anterior. So this one, you have to learn it well to remember which area are you looking at. So here I have ST elevation where in lead 2, in lead 3, in AVF. So where is the problem? In the inferior segments, in the inferior wall of the heart. If it's in the inferior wall of the heart, which arteries supply the blood perfusion to that area? It's or the right coronary or the left circumflex. If I see it in the lateral segments, I know it's the circumflex, left circumflex, or diagonal. And when I see whatever I see in the V1, V2, V3, V4, it's the left anterior descending. Just remember the heart has three big arteries. The LAD, left anterior descending, the right coronary, and the left circumflex. So here we see ST elevation where? This one is, I think they made a mistake. Yes, this is lead 1. Lead 2, lead 3. This is 2 and 3, and AVF. On the other side, V3, V4, V5, V6. Where is the ST elevation? Remember, lead 2, lead 3, AVF is inferior. V4, V5, V6 is lateral. So inferolateral. Here again, where is the ST elevation? In lead 2, in lead 3, and in AVF. On the other side, also V4, V5, V6, actually V2, V3, V4, V5, V6. So it's inferior, definitely. Also part of the anterior and the lateral. Here you have, again, lead 2, lead 3, AVF. Were involved? Definitely. But V3, V4, V5, and V6. So inferior, anterior, and lateral. That patient has a big infarct. Here you see ST elevation. You already see a Q wave. So there is necrosis already. But ST elevation in V1, V2, V3, V4, and a bit in V5. So we are talking V1, V2, V3, V4, and a bit of V5, which means involves the septum, the anterior and lateral segments, which is definitely the left anterior descending. Here, mainly V4, V5, and V6, a bit in V3. So anterolateral. V3, but mainly V4, V5, and V6. Again, where do we see ST elevation? In lead 1, AVL, mainly lead 1, AVL, V5, mainly lead 1 and AVL. Lead 1 and AVL, lateral leads. So I think I drove you mad enough for one day. Please ask me if you have any questions. Are you there, or everyone is dead or asleep?
We are here, Prof.
Okay. Please ask me now, or you can send me WhatsApp when you have any doubt about any ECG, and with pleasure, if I can, I will help.
Professor, I've got a question.
Yes.
Will this session be available? I saw that someone was recording it.
Sorry?
I saw that this session was being recorded, and I'm just inquiring if it's going to be available.
I have no idea. I didn't know they were recording it.
Okay.
Okay. The professor will be repeating the sessions, and we're going to do a more advanced course in February, hopefully, depending on the professor's availability. We'll do a more advanced course, and we'll cover the basics as we have in the past 3 lectures. So we'll be in touch with everyone as we have been. We'll be sending you WhatsApps, emails to register as soon as we've got time of availability for the prof. Thank you all for attending. And Prof, it was wonderful. Thank you very much.
My
And
pleasure.
if no one has any questions,
And happy holidays.
happy holidays to everybody. All right, and we will organize more sessions next year, depending on Prof's availability. Thank you very much from EMD.
Yep.
I hope you enjoyed it.
Thank you so much.
Thank you. All the best.